well. We start, and I will let you know something about this, I would say, relatively interesting ongoing international trial for a very, very rare disease. It's called Sacro trial for sacral chordoma. The name, if you mix all the letter of the trial, then you get Sacro, and this was the idea of Professor Paolo Casali, the medical oncologist in Milan. So the background is that, of course, such a thing as an inoperable pelvic tumor does not exist. You have inoperable tumors close to vital organ, but you can sacrifice any organ in the pelvis. So you can perform very mutilating surgery. The problem is that there is a point in which people are not so happy to perform this surgery, and most importantly, to receive this surgery. And a very good friend of mine and one of the excellent spine surgeons that has performed a lot of sacrectomies, so Professor Varga in Budapest, used to very synthetically and precisely describe sacrectomy as a barbaric surgical procedure. So we are trying to find something to spare the morbidity of sacrectomy to the patient. And this again started in Japan when they had these tumors that could theoretically have been resected at great cost for the patient, cost of high risk of wound, dehiscence, infection, complication, high risk of staying in hospital several months, high risk of chronic pain, of double incontinence, and maybe even of loss of sensory motoric function in the limb. But it's not true they were unresectable, but they were things that were really horrible, and patients were extremely motivated in finding alternatives, and even colleagues. And so in the historical Japanese data, those large chordomas could be controlled using carbon ion as an alternative to surgery. And these results published by Dr. Imai are really comparable with surgical results. So in Italy, when we had carbon ioning now, there was a very, very strong tradition of surgical orthopedic surgical oncology in the spine in Italy. There were excellent centers all over the country. When you go to congresses and you say you are Italian, not always that they ask you but if it is a congress about spine tumors, then everyone knows all the colleagues performing this wonderful procedure in Italy. So we had excellent surgery, and they were not happy to perform these procedures. There were the Japanese data, and we said, what should we do? Send you only the inoperable patient, send you the patient that could be operated but refuse surgery, send you all the patients that could be operated, but we do your treatment instead of surgery. And we said, we want to design a trial and demonstrate if the Japanese data are true. Of course, it's not a matter of trusting or not trusting, but just of following the normal procedure of reproducing good data outside the institution that did them before, and verify they are reproducible, and do them in a prospective way, comparing it. And the other thing is, yes, we are better than surgery, but is it truly confirmed that the toxicity of irradiation with high dose carbon in those tumors is better than surgery? So because of that, there was this sacral chordoma randomized and observational European study, and then now it's no longer only European, in which we decided to compare prospectively carbon ion radiotherapy. And then we said, well, but is it really true that only carbon? And indeed, the idea of using particle therapy instead of surgery and not after surgery for bulky sacral chordoma started in Japan with carbon, but then colleagues said, yes, but I could indeed do the same also with proton. So in the trial, you can do high dose carbon, you can do high dose proton, and that will be the radiation only option. Or you can do surgery, and if you do surgery, it can be surgery alone if you achieve nice and wide R0, or it can be surgery plus radiation. So the idea of the trial is really, and we got the Chordoma Foundation involved, and it was designed with very little financial resources, but with the support of the Italian sarcoma group. So again, the idea of this trial is we want to compare prospectively what happens to patients that do and do not receive surgery. Option only radiation is indeed only radiation with carbon ion, but also proton is allowed. And option surgery is surgery, but if needed, you can give post-operative radiation. So it's not a pure surgery versus radiation, but it is no surgery versus surgery, yes. And then colleagues from Budapest, so again, Professor Varga said, yes, but sometimes we really do a non-oncological debulking if you, and then we said, even the radiotherapy arm can have a bit of surgery, but it would not be considered adequate. It would not be the total sacrectomy. And we were all aware of the fact that it's not so easy to randomize patients between surgery and radiation. And so far, all the attempts, let's put it bluntly, have failed. Even in such a good indication like early stage lung cancer, in which there is never-ending debate, segmentectomy versus SBRT, randomization doesn't work. If you are a doctor and you want to produce a nice paper, it works. But if you're a patient and then they tell you we flip a coin and according to the results, either very high dose radiation or surgery, he will not accept. The surgeon will tell, okay, radiation, you have second cancer, you have all sort of horrible side effects. Look at the survivor of Hiroshima. Do they look like happy? So come with me. I take the tumor out. This is the way to go. And then the radiation oncologist will tell the patient the surgeon is really a butcher. It's horrible. We'll cut you open. I don't touch you. No blood, no pain. So the patient does not want to be randomized between surgery and radiation. That's just a fact. So what we thought was maybe we could find a small cohort of patients that will be randomized. So this is an innovative trial design. We say a prospective arm of non-randomized patient with radiation, a prospective arm of non-randomized patient with surgery, and we use them to produce a sort of pre-trial probability. And then a very small sample of randomized patients will be used with Bayesian approach to verify that the so-called pre-trial probability difference or lack of difference is the same. And why were we optimistic that we could randomize? Because in the initial investigator meeting, there were surgeons from Norway and from UK, and they said, well, you all have your strong opinions because you have referred patients to carbon ion, but we have never done that. We have no idea if it really works or does not work. So we will randomize the patient for the study. So the Italian patient, the group in Bologna said, we don't operate sacral chordoma anymore. We send them all to carbon ion. The group in Milan said, yes, but only S1, S2, S4, S5, I still operate. So everyone had a very clear idea of what they wanted to do. But the colleagues in Norway and UK and other countries with less exposure to it said, no, we are willing to randomize. So that was the design. And the endpoint was really, or the goal was really to confirm, number one, that radiation is as good as surgery, that you are not depriving the patient of a chance of cure and long-term survival. And number two, that yes, indeed, quality of life is better and toxicity is less. So that was the main idea. And to do that, we decided to, sorry, we go back to inclusion criteria later. We decided to have as primary endpoint relapse-free survival. That was the main thing. It is not really ethically so trivial to tell the patient, surgeon says you can be operated, but I tell you I can do the same, and I can do the same but better because less toxicity, so don't be operated, come to me. Yes, we have wonderful data, but it's really tricky. So the initial, the first endpoint is relapse-free survival, and the secondary endpoints are overall survival, morbidity, etc., whatever you would expect in such a trial. So going back, and apologies for the flow that's not really perfect. What were the inclusion criteria? We wanted, of course, a pathological confirmation of chordoma. Sometimes it is described as chordoma, but it is not. And after very, very long discussion among all the participants, we decided that staining for brachyury was mandatory. And if the patient has a diagnosis of chordoma based only on morphology and immunohistochemistry without brachyury, then we request additionally histo. And we didn't want to have children. It was just mainly because of regulatory issues that made it very difficult. And the patient had to be a candidate to surgery. So we wanted to show that in patients that could have been resected, we were able to achieve the same results. Not in patients that were so advanced that they were not candidates for surgery. Now, what are the hard criteria for resectability in sacral chordoma? Again, colleagues in Mayo Clinics in Rochester, they can even sometimes perform hemisommectomy. They chop the patient in half. So you can say it does not exist an inoperable sacral chordoma. The criteria was just the opinion of the surgeon if the patient was operable or not. And the flow chart again is this: if the patient can be enrolled, then we suggest to the patient to be randomized. If he accepts, he's randomized. If he does not accept, he goes in the prospective cohort. Prospective can be radiotherapy or can be surgery. And if surgery turns out to be non-zero, you can still add radiotherapy as a post-operative mortality. So this is patient or investigator choice, and this is the randomized group. So 3 arms: go for surgery, which might be surgery plus radiation according to histology, go for radiotherapy, or be randomized. And this is the last interim analysis. So last so this is not up to date. It is October last year, but we had 7 countries, 23 active sites, many European countries, Japan and the US completing the procedure to open the trial. So this was a nice group for a very, very rare indication. To just remind you, it's less than 1 patient per million inhabitants per year. And if you want to call a tumor rare, it is, according to the Rare Care Project definition, 6 per 100,000. So even if chordoma were 10 times more frequent, we would still call it rare. So it's a super rare indication. Nevertheless, just because of the great work of the patient advocacy, so Chordoma Foundation is doing a great job. And just because chordoma, if you have someone that has heard about particle therapy, will immediately make a connection particle and chordoma. So it's a very well-established modality. So despite this rare among the rare tumor, it's hard to find something that is more rare than sacral chordoma. We could enroll 136 patients. This was a major achievement, showing how well that the network is established and showing that you can do prospective trial even in very rare disease if you really rely on established network. And this is the accrual that really went as expected since 2017 to it is here up to 2021, and we were at 90, and now we are 136. So it's really going as expected, just because it's happening that sacral chordoma is referred to referral centers, and there are not so many, and they all know about it, and they are all happy to participate. 89 patients. These again, now we are at 136, but this analysis is based on the first interim analysis where we had only 89 patients. So I apologize that I don't have the data for the 136, but this will happen in autumn that we do a second interim analysis. And of these 89 patients, what we have seen is that a little bit less decided to go for surgery, and a little bit more than half decided to go for particle therapy. And of the particle therapy, almost all the patients were treated with carbon ion, but now the center in Essen is more actively participating. So in the next interim analysis, we will see some more patients treated with high dose protons. And also, not surprisingly, we are stratifying this patient according to high or low location. If the patient is low, S4 and S5, then in S4 and S5, we have majority going for surgery, 80%, but still 20% going for radiation. And instead, in high tumor where surgery is indeed more toxic, higher risk of morbidity, then here we have 80% of the patient deciding for radiation and only a minority deciding for surgery. So this is as expected, and no surprise there. In this patient, surgery was performed again all in referral center with a lot of expertise. Despite that, there is still some inhomogeneity. it is not like every expert sarcoma surgeon operates the sacral chordoma in the same way. Even only from the back, so single access or double access, even there were discussion and there were different techniques used. Of course, there is no R2. Well, you would expect that in such a trial. If you are not really going to do surgery and leave macroscopic tumor, it happens in a small peripheral hospital, and fortunately it doesn't happen. But there is still a disturbing 14% of R1. So R1 is really bad for these cases, and these were really patients in a trial where we were all there trying to do our best. So it really shows that when you compare results of surgery, you should not compare results to R0 surgery, but to something that is planned to be R0, but turns out to be more than one every 10 patients, not to be R0. So you have surprises even in this case. And it happens even in expert hands that the tumor is broken during removal, and then all the operative field is contaminated. And for radiation, there were different schedules used, but the most common one was by far the carbon ion radiotherapy, 16 fraction of 4.6, and then some patients were treated with 16 fraction of 4.4, and this was mostly in Italy now in patients in which we and then they, when I moved, were afraid of sacral insufficiency fracture, which is the main, I would say, one of the two main issues with radiation. And then these patients are now more, they are treated in Essen with the SIP. So this was a practical world trial in which each center was allowed to use its own schema for treatment. And toxicity of radiotherapy, well, what is nice is that there was no grade 4, but what is less nice is that there were a 2-digit of grade 3, and the pain was the main issue. Sacral neuropathy, so damage to the pain, to the nerves performed by the high dose radiation is indeed something. Now, it is not always so. Bone fracture, this is very tricky. If you listen to Dr. Kamada, it tells you that this is 100%. But depending on how hard you look, you can always find a bone fracture in this patient. So the point is, how many of these painful patients are due to bone fracture, and how many are due to pure neuropathy? And this is something we are trying to investigate at the moment. And the toxicity of surgery, there were really non-negligible percent of patients with complication in the perioperative period. So 40%, and of this 40%, 60% had Clavien-Dindo grade 3 complication. Now, we are scoring RT toxicity according to CTCA, and surgeons are scoring according to Clavien-Dindo. Just be aware that the systems do not match. A Clavien-Dindo grade 3 corresponds to a CTCA grade 4. Surgeons are much more willing to accept toxicity because they are convinced that this is in the perioperative time, and then it will go away. And radiation oncologists are more scared of toxicity because we have a feeling it will happen late and will stay with the patient for a very long time. But if I have a necrosis and the patient has to go to the operating theater to get a necrosectomy, I call it a grade 4. I am very unhappy. If the surgeon has a wound dehiscence and the patient has to go back to the operating theater, it's the second time. So he says, okay, yeah, that's what I'm doing. I already operated once. I have to operate twice. It's not a big deal. So that's a Clavien-Dindo grade 3. So again, this is a very interesting meeting of different cultures. We were all a bit surprised by how scared radiation oncologists are of toxicity in the eyes of surgeons, and how relaxed surgeons are of toxicity in the eyes of radiation oncology. This is, of course, a very personal point of view. It's just my point of view that I'm giving you. There was only one grade 5, one patient that had hemorrhagic shock and died at day 30 after operation. This is interesting data. at interim analysis, relapse-free survival is identical in surgery and in radiation, but also here at 30 months, results are not spectacular, but this is very, very small number of patients with a long follow-up. So it starts to be a super wide confidence interval. What we know is that up to 2 years, where patient numbers is still meaningful, we have confirmed so far no difference. Now confirmed, of course, we are lacking the randomized samples. These were all patients in the non-randomized arm. The initial idea of the colleagues from Oslo and from Birmingham was not confirmed. No patient accepted to be randomized. We are still happy, but the bright trial design didn't translate into reality. So far, we have a prospective comparison of cohorts that we match exposed according to tumor size, but there's no randomized part. But is this still prospective group of patients that were all candidate to surgery or to radiation? Results are superimposable in terms of relapse-free survival. Results are superimposable in terms of overall survival. Now the trial is going on, and it was designed to last until the randomized part would provide stable estimates for the prior probability. And if the randomized part is not recruiting, this will never happen. But it was always agreed among the investigators that this trial is also a way to give the best standard of care to the patient. And as the treatment is loosely defined and allows for improvement, we are continuing with the trial to increase the number of patients and the length of follow-up. Now, very briefly, those results you have seen were from patients treated 2017, and of course, most of them with carbon were treated in now. Then also in MedAustron, we started, and what I want to tell you is that there was an evolution. So we have changed and improved the way we treat. So this is not MedAustron versus now or MedAustron versus trial. It's just the old way versus the new way. We have increased the dose to the rectum, taking into account the evaluation of MKM and LAM. We have given more strict rules about beam placement to avoid cold spot in terms of LET. We are making sometimes more use of spacer to separate the rectum from the tumor. And these are the results now of sarcoma patients treated within and without the study in MedAustron. So this is not a comparison. There is no possibility of drawing conclusion, but there is possibly a hint that even our European experience of sarcoma treatment is going in the right direction and not in the wrong direction, because this is a curve I would like to have rather than this. It seems our new treatments are performing really well because of several issues, including better optimization in the software. How do you score results? With surgery, it's very easy. If there is no tumor, there is no tumor, and if there is something, it is tumor. And with radiation, RECIST doesn't really work. What we are doing, we are contouring the tumor at each follow-up, and then we are following volumetrically. And what you see is that over the years, it shrinks. Now, what is different between the old patient and the new patients? In the old patients, we were mostly trying to spare the risk of sacral insufficiency factor. And now we are giving a bit more dose, accepting this risk. Now, this is still a debate, an ongoing debate. Rectum, in the beginning, we were extremely afraid of high risk, high grade rectal toxicity. This never happened. So we say, get rid of the PRV and increase the dose. The software used initially was one and now is another, and this is simply performing better in terms of dose homogeneities, spacer to separate the rectum, and also in these past 5 to 6 years, we have gradually gone toward a reduction of CTD1. So to reduce the risk of sacral insufficiency factor, we are really discussing how much of non-involved bone is really mandatory to treat or not to treat. I cannot but put one case just to put some practical things. And yes, this is a sacral chordoma treated with carbon ion by us, but not in the trial. So why do you show it? Just to show you that we are talking of comparing a modality that is used in tumors that would have really very little chance of being cured without surgery. You see how bulky was the disease. You see this was a more than 1 liter of GTV of sacral chordoma, and the young man came to us with uncontrollable pain despite maximal dose of fentanyl patch. He was lying on a stretcher in severe pain with a diaper for urinary incontinence, with complete erectile deficit, not able to stand, not able to walk, very, very poor quality of life. And the treatment was done with carbon. You see 1, 2, 3 beams. You see that in terms of dose distribution, it's very similar to protons, with possibly easier because of the small spot and sharp penumbra. It's slightly easier to create this selective nerve sparing. We are routinely trying to spare selectively the non-involved nerve roots. And there is indeed in this patient a quite amazing response. So at 12 months, you have the tumor going from more than 1 liter to 600 milliliter. You have the patient from the stretcher to the paragliding. His favorite hobby was paragliding, and he went back to paragliding. And you go from complete urinary incontinence plus diaper plus erectile deficits to a new girlfriend. So this was the reason why we are saying the trial will show that this is more gentle than surgery and as effective as surgery. Because indeed the pre-trial anecdotes, they are anecdotes, but they are so strong that we could convince all our colleagues to participate into this. And stay tuned because 130 is a nice number, and now we are waiting for longer follow-up, and then we will be able to publish these results. And with this, I thank you so much, and I will be able to take questions. But
I have a question regarding one of the previous lectures in hypoxia. Could you explain
question
time
for
the graph
Pierro
inside
regarding one of the previous? This is several days ago, and this is a graph showing that if you treat a tumor that here is indicated with the gray solid line with the white target. So you come from the left of the screen and you deliver an SOBP. And the SOBP is just one single beam coming from the left. So all the particles will stop on the right side. So the right side will get a lot of high LET, slow particle density ionizing. And the left side will get a lot of those from the plateau. And then you can see that the dotted line, that is the dose averaged LET inside the target, and it goes up and up and up. And the different lines are the oxygen enhancement ratio. And the oxygen enhancement ratio tells you how much more dose of this radiation you have to give to kill the well oxygenated as compared to the purely oxygenated cell. So a high oxygen enhancement ratio means that oxygen plays a big role, and the low oxygen enhancement ratio means that oxygen plays a small role. And why do we have different curves? Because you can have a lot of oxygen versus no oxygen, so 160 millimeter versus 0.01. So that is the most extreme condition. So the number in brackets tells you how up in an oxygen, how well oxygenated were the two sets on which you measure. So if you have a small difference in oxygenation, you will see no difference. But if you have a big difference in oxygenation, then your oxygen enhancement ratio of a single beam of carbon will go from more than 2 in the proximal part of the SOBP to 1.3, but not really 1 in the distal part. So this was a way to show quantitatively that with carbon, oxygen is less of an issue, but it still is an issue.
I'm not seeing any other questions, no raised hands. So thank you, Dr. Fossati, for your lecture.